All right. And so as always, this will make the meeting available within a week on our website, probably less than that. And so today we have a few things to talk about. First, this is our first call of the year. Yay! It's a bright new year ahead. We're looking forward to it. Well, I don't know about that. There's a lot of nasty elections in a number of countries and a lot of some amount of fear and concern, but we'll all go for it together at least. And so on our agenda today, we'll talk about vaccines and what to expect in malaria and TB. We'll talk about the RISE study and take a first look at the results. It's a study of civil society and community in CCMs. And finally, we'll quickly talk about our 2023 annual report. But before we get going, we have colleagues from GFAN Asia Pacific who wanted to take a couple of minutes to thank our colleague Niluka, who is leaving us for greener pastures in Geneva. So I want to give the floor to Rachel, if you're here. I don't see her in the list. She's not here yet. We're gonna go ahead and we'll come back to that then. So I give the floor to you, Delphine, to tell us everything about malaria vaccine, and we hear quickly after that from Mike before taking some question.
So I won't pretend to say everything because you've given me 10 minutes and I'm not a malaria vaccine expert. So I should start with that. So just a little bit, a bit of a disclaimer. So my background is I've worked for 10 years on community engagement and policy issue around malaria, and I'm not a vaccine expert. I'm not a biologist. So if you have more technical question, I think we should plan some kind of follow-up with a real vaccine expert, let's say. But GFAN asked me to provide an overview to help, especially on advocacy issues. I'm a consultant for a number of organizations, all listed here, and that all have a relation to malaria. I work more on vector control, so I wanted to say that in terms of a conflict of interest potentially. I want to maybe forward all that to say that Friends of the Global Fund Europe is actually working on a position paper on this actual issue and what it means for GFAN. And yes, I'll start that. So views are my own with my little expertise on the topic and not from these organizations. That being said, so we thought that vaccine was an important question, and first to say, when talking about malaria, we're talking about vaccines in plural because we currently have 2 vaccines that have been approved by WHO, recommended, and they are both vaccines for Plasmodium falciparum malaria. So that's the majority of deadly cases of malaria across the world. It's by far the majority of cases in Africa. But of course, there's other Plasmodium, other parasites that are not covered by these vaccines. So 2 of them, the first one, and they both have not such easy names to remember, but the first one's called RTSS. It was developed by GSK, and it was recommended in October 2021. And it went through a pre-qualification process. So I won't go into the details of what PQ is because it's a very complicated process, but it's overall a process to guarantee the quality of the medicines and medical products that are then available for purchase and rollout. So this first vaccine has gone through PQ, so it's now available for people like Gavi and others to purchase this vaccine. The second vaccine, called R21, was developed by Oxford University and trialed. I should say the first vaccine, the phase 3 trial, was done by WHO, funded by WHO. And the second one, it was the phase 3 trial was done in partnership with several African research institutions. It was recommended last October. It is ongoing, the pre-qualification process. So it's that's going to be a condition for its availability for purchase by UN and multilateral organizations. So that's why today, when we're going to talk more about what's being talked about these days, about the malaria vaccine being rolled out, we'll talk more about RTSS, even though the other one is coming soon, but it's not yet available for example, for Gavi to take it up. These vaccines, in both cases, they are for children above 5 months old. And the focus, the kind of policy focus is on children under 5 years old, due to limited availability of the vaccine, but also due to the fact that the deaths are in this group in majority. Over 90% of deaths of malaria are in children under 5 years old. Key facts on RTSS. So I try to keep it really simple. I've given a couple of the most obvious references if you want to dive into this. So key facts, it's a 3 doses vaccine. So you need 3 monthly doses of vaccine for children, and then a booster after a year. And you see in this graph here, you see, so once you've had the doses, and then you see that the decline of the antigens is quite rapid, and then you have the booster, you gain that, and then it falls. So in that way, some people have said it should almost be called a seasonal vaccine. So it doesn't protect you. It's not like what people might be thinking for other kind of vaccines that you get when you're a child and then you're kind of done. This is more a seasonal vaccine, and actually in the settings, in the African settings where malaria is highly seasonal, which is, for example, the case in the Sahel region. Its best efficacy is when it's administered just before the malaria season. So there's a whole programmatic question. That's an important case because it means the rollout in high seasonal countries, for example, as I say, Sahel, or in countries where you will have more a steady transmission. If you think, for example, some Eastern African countries will be different. And another factor to consider, as we know, climate change impacts a lot malaria transmission, and it impacts in particular the seasonality, making it more difficult to have a seasonal prediction. The results are also that its best efficacy, it's when it's combined with SMC, and so for non-malaria people, that's the seasonal chemoprevention. So that's basically it's the administration of a prophylaxis to children on a seasonal basis, which Global Fund is responsible of doing. It reduces, when you use them jointly, you can reduce really significantly the episodes of severe malaria by 70%, and the all cause of death by 53%. And so it has a really significant impact when you administer it jointly. I've put here some of the phase 3 efficacy results. You see that you do need these boosters, and the results are not like a fantastic one. So don't think about this vaccine as something that you do once and then you're covered and it's all over. I think that's kind of the key message on this vaccine. The initial deployment. So when this was approved, Gavi launched a call for interest from countries, and they reported an unprecedented demand for malaria vaccine. And I think that reflects the fact that the malaria community has been waiting for vaccine for decades. Many research projects, many hopes, and a lot of those were disappointed. So it does reflect that there was a really high demand. 28 countries expressed their interest. The current availability is 18 million doses that's been allocated to 12 countries for subnational allocation. So that means it's not a national rollout where you're like, okay, you, like, let's say Cameroon, because there've been a lot in the news, Cameroon can roll out for all districts, all children. It's been prioritized in a subnational level, considering malaria transmission and burden. So that's where we are at the moment. And an important fact on the RTSS vaccine is the current production capacity is only 15 million doses a year. And remember, it's at least 3 doses plus a booster. So it's kind of 4 doses for every child. and potentially an annual booster after that to keep the protection. So it's not 15 million people vaccinated every year. The Gavi has estimated that the annual global demand for the vaccine will be between 40 to 60 million doses by 2026 and growing to up to 100 million doses or more each year by 2030. The arrival of Article 21, the second vaccine I mentioned, is considered really critical to meet the demand, and that was actually a key part of the recommendation. Because as you know, when WHO recommends any new tool, it has to bring something more to what's available. So this vaccine was considered critical because the production capacity here is much broader, to 100 million doses a year. I won't get into these details, but basically it's largely due to the fact that that the all adjuvant question, it's first cheaper and easier to produce because there's not the same kind of patent issue. What's in the SAGE report, so that's the technical report of WHO, is very, very clear. It says that the RTS vaccine is a complementary tool. And I think if you remember one thing from today, that's the one sentence to remember. And that says that the bed nets, insecticide-treated bed nets, are a proven and cost-effective intervention. That seasonal malaria chemoprevention is also effective in highly seasonal malaria. And that case management is really critical, regardless of the other preventive measures. So in the report, that's the report that that kind of technical report that served to WHO to recommend the use of the vaccine. And they were very clear of showing, yes, the vaccine is great, but don't forget that there's all these other tools and they do need to be continued, because otherwise we really have a big risk. I wanted to, this is really a really quick snapshot, different languages, but this is only over the last, I think, week or 2 weeks, because Cameroon has started rolling out the vaccine, and there's been a lot of coverage, and that's all over on all the markets that we serve, whether it's the US, the UK, Europe, Africa as well. So a lot of coverage on this vaccine, again, because it was waited for a really long time. So as I said, I'm not a vaccine expert, I'm more policy advocacy expert. So I thought I should lay down the advocacy challenges here. The first thing is, as I say, there was very high expectations after decades of research. And so there's really high hope in an endemic country about the idea of a vaccine. This is one of the other complexity in terms of advocacy. It's a partially efficacious vaccine. It's not like, okay, I'm getting my shot and then I'm protected and that's kind of done. It does require to work with other tools, and this has to be kind of hammered back on people and in the messaging. It's not a one tool. It's not the vaccine on its own, and all the recommendations are extremely clear. It's very important, therefore, that the message to community and government and funders is this vaccine is not a silver bullet. All the policy documents over the last decade in malaria have all said that the only way to end malaria is to have a combined approach where you have vector control, you have treatment, diagnostic, prevention like SMC. So we need to say that. And in particular, this has to be said to communities, because, you know, we've seen with COVID, for example, like the difficulty for people to understand that even though you have a vaccine, especially if it's not 100% efficacious, you might still get the disease. You might have less severe cases, but you might still get the disease. So we need to make sure the communities understand that, and so that they keep putting the children under a bed nets to sleep. They keep bringing them to SMC. And otherwise we risk that this actually has a really negative impact. The other question is, as I say, it's partially efficacious. So we need to think how this tool fits into a broader strategy to eliminate malaria. I thought I should put back this because I think it's a very important fact in malaria. 68% of lives that were saved in the last 2 decades were due to bed nets. So the vector control is the most efficacious tool that we have. It's largely proven, and we have challenges on vector control with the emergence, or it's more than emergence now because it's widespread, of insecticide resistance, of behavior change. So that's why we have new nets that the Global Fund has started supporting the deployment of. But so we need to think about what that means, and we need to make sure that we don't have all the money going to a strategy that's not a silver bullet. And therefore, we need to make sure that people understand that we now have a bit of a new landscape, because in the old days, until now, if you were thinking malaria and multilateral, you would be thinking Global Fund. It's in its name, Global Fund for the fight against malaria. But now you will also have Gavi, and one of the challenge will be in the upcoming replenishment that these two organizations don't appear as competing, but they appear as complementary, because the vaccine requires SMC to be effective. And so therefore you have a need for a very strong operational joint strategy. How are they going to deploy both in villages so that the child that gets vaccinated also gets SMC doses? And also advocacy joint strategy. So this is the challenge ahead of us for the coming year, to make sure that while people get excited about this vaccine, they don't forget that they still need to fund bed nets, chemo prevention, treatment, and diagnostic. And that was it. I tried to be short, Quentin. I hope that was the case.
Thank you very much. So without taking questions yet, we'll move on to Mike's presentation, the TB vaccine, for extra context. Then we'll take a few questions from the room. Mike, the floor is yours.
Okay, thank you. Let me just pull up the slides. I also prepared just a very short presentation. Hi to everybody. I'm Mike Frick from Treatment Action Group. I co-direct the tuberculosis project there, and I focus on advocacy for better ways to prevent TB, including research for new TB vaccines. So happy to give this overview of TB vaccines and to call out some things that I think advocates should watch for in 2024. And if you want more information, we publish an annual pipeline report that summarizes progress in TB vaccine development that's available on our website. So without further ado, the first thing I wanted to say by way of scene setting is that we also are not talking about silver bullets, new TB vaccines once they are developed and available, and we're still in a research phase in the TB world, unlike malaria. Once we develop new TB vaccines, they will be one of many ways to prevent TB. And we already have a lot of powerful prevention tools in tuberculosis. So there's infection control in clinics, communities, and households. Preventive treatment is probably the most powerful biomedical intervention, with short course regimens of TB preventive treatment. The shortest being the 1HP regimen, which is just 28 days of therapy, reduced from standard 9-month isoniazid preventive treatment. So things there have changed a lot. We do have vaccines, a vaccine called BCG, which is protective of the most severe forms of tuberculosis in infants, but its efficacy wanes in adolescents, and it doesn't offer much protection against pulmonary TB to adolescents and adults. So that's why we're working to develop new TB vaccines, and the focus is really on developing vaccines for that adolescent and adult age group. ART is also very protective against TB for people living with HIV. And I put nutrition on this slide because a really landmark study in India last year showed that just the sort of simple, important, basic act of supplementing households in terms of their food security greatly reduced the risk of TB among household contacts living in homes where someone had TB by about 50%. So just making sure that people are well fed is incredibly protective against tuberculosis. And all of these interventions rely on respect for human rights, human development, social protection. So these are not discrete choices. It's not do this or that. They're things that will work better together and are more powerful if we use them together. And when we develop a vaccine, it will slot into this wider prevention landscape and be something that we should use in combination with these other interventions. So that said, I wanted to show you the vaccines that we're working to develop. This slide shows you the pipeline of TB vaccine candidates under development by name and by phase. The colors tell you the type of vaccine that it is. What I want to point out is a couple of exciting developments. We've been very focused in TB on the fact that we have a lot of different candidates in phase 3 trials, and 2 of those are expected to start this year. The candidate that has received the most attention is actually the last one listed in phase 3. It's M72 AS01E. This is a candidate that actually shares a little bit in common with the malaria vaccines. The AS01E is the adjuvant, and that is basically the same adjuvant as in the RTSS vaccine. This vaccine was initially developed by GSK and is now being taken forward by the Gates Medical Research Institute. This adjuvant also shares a key ingredient with the adjuvant in the R21 vaccine, the other malaria vaccine. So there's a little bit of common challenge in terms of some future concerns we have about M72 access and affordability based on the experience that our malaria colleagues are going through now. But that phase 3 trial sponsored by Gates and the Wellcome Trust is expected to start sometime this spring and could enroll upwards of, we're hearing, between 12,000 to 26,000 people. So it would be an enormously large trial by our standards. The other vaccine that is beginning phase 3 trials this year is MTBVac. This is being taken forward by IAVI. It's a vaccine that's coming out of a small biotech in Spain. And in December of 2023, they announced that they had secured funding for an efficacy trial with money from Gates, Open Philanthropy, and the German government. I also just want to point out in phase 1 that we have some new things that people are very excited about, including the first mRNA-based TB vaccine candidates. Those are in phase 1 trials and are sponsored by BioNTech. And those studies are happening in Germany and in South Africa. So there's a lot to pay attention to, but definitely the focus is on these phase 3 trials. And just to set expectations, these studies are going to take some time to complete because you enroll people, you vaccinate them, and then you have to wait basically until you see a certain number of people develop tuberculosis in order to evaluate efficacy. And TB is not like COVID. It's not something that you develop 2 weeks after you've been exposed. It is more like something you develop a year or 2 years after exposure. So the studies are going to have a certain follow-up period, and they could take anywhere from 4 to 5 years or more to complete. So we're talking about a timeline of really 2027 at the earliest, if things go really well, 2028 onward until we have definitive results from some of these late-stage trials. This slide just shows you the pipeline again by the numbers, just to give you some quick facts if you want to reference them later. We have 17 candidates at various stages of development. I wanted to highlight that 5 trials include people living with HIV. These studies are happening in 28 countries on 5 continents. And if you add up all of the participants expected to take part in those phase 3 trials, it's more than 80,000 people. So that's more people than have participated in a TB vaccine study since the middle of the 20th century, when India ran some very large studies of the BCG vaccine that involved hundreds of thousands of people. So a lot of people are participating in TB vaccine science, but we have a serious funding problem. Last year, according to the TAG and Stop TB partnership data, only $143 million was spent on TB vaccine research. That's like, pennies on the dollar of what's spent on COVID vaccines or other areas of vaccinology. And we need about $1.25 billion a year. So we have a big R&D fundraising issue that we need to address. I wanted to just show you a little bit more information on these 2 candidates that I highlighted that are expected to begin efficacy trials this year. M72 AS01E is a subunit vaccine. The M72 part is the protein that comes from tuberculosis, and AS01E is that adjuvant. This is a trial that Gates and Wellcome are sponsoring. They've jointly invested $550 million, Wellcome providing $150 million of that, and Gates making up the remainder. They're basically taking over development from GSK, which has retained rights to the AS01E adjuvant and will supply that for the trial and commercialization, but is not actually running the trial itself. And then there's MTBVAC, which IAVI is moving forward with the Zendal group with some money that they've raised. MTBVAC is a really interesting vaccine because it's actually the Mycobacterium tuberculosis, the TB or the bacterium that causes TB itself. That is the vaccine. And basically what they've done is deleted 2 genes from TB to attenuate its virulence and make it safe for human use. So that vaccine is like giving tuberculosis that has been genetically weakened to somebody. And the idea is that by doing that, you present all the antigens that TB itself would present when it infects somebody, and you'll generate a really robust and comprehensive immune response. So 2 very different vaccines in terms of their construction and approaches, but both will be studied in adolescents and adults. And the MTBVAC study will be focused in Africa as we understand it. The M72 trial is enrolling in Africa, as well as places like Indonesia and Vietnam and some other countries. So I want to point out that promising science is no guarantee of success. And just last December, one of those candidates in phase 2 reported very disappointing results from a study that was looking at whether this vaccine could prevent recurrent TB, that is developing TB again, among people who had already had it. And this was a vaccine candidate out of Europe, Denmark Staten Serum Institute, called H56IC31. And the study, which released top-line results in December, showed that not only did the vaccine not protect people against recurrent disease, those people in the trial who received the vaccine actually appeared to have a higher risk of developing TB again than people who received the placebo. So, like, really not what you want to see in a vaccine study. The Global TB Community Advisory Board issued a statement in response to these results, and I'm quoting our co-chair, Ani, who said that, you know, this is really disheartening, but the trial had really high standards of care for those participants. It was contacting all of the participants to inform them of results, working with local community advisory boards. And there's really a need to look more closely at the data to see what went on here. But this is just to stress that, you know, we could have disappointment or we could have success, and we need to be prepared for either. You know, there's been a lot of noise made about our pipeline and how excited we are by it, but things may not work, and we have to be ready for that too. And then just to say that a lot of people in sort of anticipation of success are already talking a lot about delivery and how we would deliver new TB vaccines. And I think this is where I really look to GFAN and others for guidance, because it's not clear who would lead on TB vaccine delivery. It's a really crowded space. Is it Gavi? Gavi has not traditionally worked on TB, of course. Is it Global Fund? Is it a combination of the two? What role does Unitate have to play? Would PEPFAR have a leading role if the vaccine was safe for use in people living with HIV? Would the Stop TB Partnership Global Drug Facility work to pool and curate demand for the vaccine? And would we look to countries to lead, South Africa, Indonesia, others? So this is an area where I think there's still a lot of ongoing discussion. And it's really not clear, like, who, quote unquote, owns this space or should be working alongside each other at any rate on the delivery side of things. And that's something that we can start preparing for now. And then I just want to talk about access for a minute, because this is common to TB and also to malaria. Last year, ProPublica published a really in-depth report about the M72 AS01 vaccine, talking about how GSK made decisions that slowed down the development of this vaccine. And it all hinged on this AS01 adjuvant, which is in the TB vaccine and the RTSS vaccine and has a common component in R21. And AS01 is not just a TB and a malaria adjuvant, it's also the adjuvant that GSK uses in their shingles vaccine called Shingrix, which is a blockbuster product for them. It's probably the most important product in their portfolio in their vaccine portfolio. You know, they earn billions of dollars a year on that. Because this adjuvant has a key ingredient that can only be sourced from the natural world, from the bark of a tree that grows in South America, there's limited supply of it. There's just some real access constraints placed on the adjuvant. And ProPublica goes into the story of how GSK privileged the supply of the adjuvant for shingles, leading to, you know, less focus on TB and malaria, but more than that, how the adjuvant itself actually was developed through US government research funded by the Department of Defense at the US Army Malaria program, and was sort of taken by GSK, much to the Army's surprise in the late 80s and early 90s, patented and sort of taken out of Army control. So another example of public funding creating a piece of innovation that's quickly spirited away by pharma, and something that we're fighting to access later. I'll let you read the ProPublica report to get the details, but this is still affecting us. And if that M72 AS01 vaccine works, there's a real question about how much supply of adjuvant GSK can make. You know, we just heard only 15 million doses of RTSS a year. You know, we don't want to be in that same situation for the TB vaccine, because this vaccine is 2 doses. So if we only get 15 million a year, that's really only enough to vaccinate like 8 million people a year. We need to vaccinate many, many more for a TB vaccine to have public health impact. So with that, I'll stop. Happy to take any questions and share slides, and links to everything I talked about are on this last slide. Back to you, Quentin.
Thanks a lot, Mike. So we'll be a bit quick on the Q&A because I don't want to squeeze the last presenters too hard. But I wanted just to give a bit of context to everyone on the call. The reason why we brought in Delphine and Mike to talk about what was happening in the vaccine space is that we have been hearing a lot about vaccines in the global health space. I think there's a lot of enthusiasm around the malaria vaccine in particular, and it's a hard one to navigate as advocates, because obviously we want to advocate for the best care and to communities that are affected, and want to make sure that innovation is quickly rolled out. But we do work in a field with finite resources, and we don't want proven and effective interventions to be deprioritized because there's a shiny new toy on the market. And so we wanted to get the perspective of people with a background to help us understand the stakes. So we have time for 2 questions if people want to raise their hand, and then we'll move on to the next presentation. Since I don't see any hands up, I do have two quick remarks. So the first one is I was surprised, Delphine, in your presentation to see that Gavi was projecting that the expected need for the malaria vaccine was going to go up, which I was surprised by. And can you tell us more about why that would be? From like 40 to 100 million in a few years. And Mike, I would be interested to understand whether, because we see the example of how the malaria vaccine has been picked up by Gavi. Do you have any reason to expect that it wouldn't be the same way for the TB vaccine, that it wouldn't fall on their lap? So to you, Delphine, and to you, Mike.
So I think we should ask Gavi to comment, but my understanding is that because it was a new vaccine, you had only a few countries that were originally interested. I mean, not a few, 28, it's not little, but it's far from all the countries where malaria is present. And I think it was also related to the rollout capacity. So I think that there's this whole question of how you roll it out, who was going to get access. So there was a whole process to make sure that the access to the little doses that we have, and Mike described very well the whole commercial issue behind it and behind this availability. There was a whole work to make sure that the doses would be made available to the high burden countries and areas. So I think this is part of why you see this increase, because if you think of the number of children to vaccinate, it is of course much higher than that. So I think it's a mix of ability to roll it out and countries just realizing that a vaccine is ready and getting it into the mix. And probably, I don't know, maybe something to look at as well of how much they anticipate vaccine hesitancy in countries where maybe other vaccines are already difficult to roll out. But I think for further comments on that, we should probably get back to Gavi.
Thanks, Delphine. And Mike, on whether you reckon there's any reason that Gavi wouldn't pick up the TB vaccine?
I think Gavi is interested. I'm sure there are people on the call who are more expert on Gavi than I am. My understanding is that their vaccine investment strategy, VIS, is considering adding tuberculosis to it in its next iteration, and that will lay the stage for more Gavi work and attention to TB. And they definitely have started showing up to TB vaccine meetings. So I expect Gavi is going to be really active in this space. I think for us as TB advocates, maybe we should be a little strategic and think about like the world we want in terms of like the role of Gavi versus Global Fund versus Global Drug Facility, some of these other TB mechanisms. And I don't really have the answers, but just wanted to raise it sort of for discussion. It's a great question.
Thanks a lot. Thanks a lot, Mike. So thanks everyone. I saw a few comments in the chat, and I will perhaps leave you, Delphine and Mike, to answer them in the chat, because I do want to move on to our next presenter. So thanks a lot both for. I think it's really good to start the year with a bit of a hard fact on both on both fields, because I think it's been lacking in particular in the way the press has covered it, and it's easy to get caught up in the enthusiasm and miss the bigger picture. So thanks a lot, Mike and Delphine. I now want to pass on the floor to Leo, who will introduce the presenters for the RISE study. Leo, the floor is yours.
Hi, everyone. Can you hear me well? Everything good? Great. Really nice to see you all on this meeting. It's a pleasure. Some of you may remember that during the last GFAN meeting in Kenya, we presented a project that was still ongoing. It was the beginning of the project. We wanted to analyze and to evaluate how community were engaged into CCMs in the Global Fund mechanism. But we wanted this study to be community-based. It was the big challenge that we had. We is Coalition Plus, AID, so my organization, the French member of Coalition Plus, but also AMFAR and the O'Neill Institute for Global Health. So we worked, all the four of us, to build this study on a community basis. And it was a tremendous work, but really stimulating and really great to work with the community experts around the world. And we had two different phases for the study, qualitative one and quantitative one. And we have the first results. We have the preliminary results. So I will leave the floor to Jennifer from AMFA, which is our colleague who worked particularly on the results and the data, and to present you some of the key figures and key findings that we had for the study. Thank you.
Great. Thank you, Leo, and nice to see you all. I'm Jennifer from AMFAR. Pleasure to be here today. And I am thrilled to present some of the early results of the RISE study on behalf of a large study team comprised of 13 organizations across 11 countries featured here. Really just a stellar team of people who made this happen from conception to dissemination and every step in between. So thank you so much. This work took place last year for data collection. It was, as Leo mentioned, a mixed method study. So we had a large quantitative data collection effort, which took place from April to October, and a qualitative data collection effort, which was really a deep dive of interviews that we collected in 7 different countries. We had our steering committee featured in that last slide, really guiding us along the way, from designing indicators to validating results, and that took place all of last year. And so we're excited to be in 2024 and have the opportunity to have some data. In the end, we got over 600 people who answered our quantitative survey, and we got close to 50 people who took who did an in-depth interview with one of our researchers in across 7 countries. And so a really robust sample, and this came from 84 different countries, which is something that we're really proud of. That geographical reach is something that I think is really important, a strength of this data set. And I have to say that GFAN and others were essential in disseminating this survey. And so just a big thank you to you all, getting this sort of results from a an electronic survey that was not independently, that was not funded externally, was really just a community effort, is just, you know, a huge success. So thank you so much. Here is who is in our sample. We decided to collect data not just among CCM members, but among broader civil society who sat outside of the CCM, but engaged closely with the CCM. So we have two major populations who we targeted. The first are Global Fund advocates who are not on the CCM, but who engage closely with the CCM and with Global Fund processes. And the second are CCM members. Within our CCM members, we targeted community groups, so people who self-identified as being part of a community organization, a local NGO, or a local FBO. And then also community or non-community CCM members. So this would be folks from government, multilaterals, technical agencies, academic, private sector, et cetera. So we really do have sort of three distinct groups of people in these results. So because we only have 10 minutes, I am zooming into our results right away. But if you have methodological questions at all, please do feel free to reach out to us. We had over 50 indicators in our survey, and so today I'm only going to highlight a few, but rest assured we have more data, and if you'd like some, we would be happy to share. All of our indicators did attempt to measure a few major things: how well community was included and participating in CCM processes, how well that participation went, was it meaningful, was it tokenizing, and then also how much power people had to affect change in these spaces and what we could do to try to build community power. So as I'm presenting results, you can see that a lot of our indicators fall along these major themes. So one of our first key findings is how important civil society pre-meetings were. These are meetings that civil society had before CCM meetings to organize thoughts, to really think about what the demands should be. And these were just vital for CCM members to gather the voices of communities and bring those to the general CCM. When we asked folks, are CSOs really supported to attend these community consultations? The vast majority, 80%, said yes, we are supported to attend, and this is great. However, when we asked, is that funding enough? We found that the minority said yes, 28%. And so, this was really talked about in a lot of spaces in our survey, that there was money, but it just wasn't enough. People were taking time off work. They had to come out of pocket for things like their travel expenses, and others, where there really was a call for more resources needed. In the CCM meetings themselves, there are a lot of barriers and facilitators to whether or not a CCM member felt that they could meaningfully contribute to that meeting. And some of them were really simple sort of logistic issues, in that the documents for the CCM were not being shared on time. There wasn't enough time to prep, and that those documents were just really difficult to understand or not in a language that was preferred for the community members. So you can see here some of the major barriers that we found for CCM members, talking about what was difficult for them. The community is highlighted here in yellow and non-community in blue, but you can see that in each category of barriers, community actually had higher percentages of barriers than the non-community folks. And when, in the inverse, when community really did have access to clear and timely information, really did have access to those documents and had enough time to ingest them, they felt much more productive in those meetings and able to contribute. Sometimes just having the documents really wasn't enough, though. There's so many other things that can happen. Understanding the politics, understanding how to actually affect change and move an issue forward. And so one of the things that we found that community members spoke about as being a big facilitator to their engagement was actually having a mentor, having someone who was part of your peer group. So not an international consultant who flew in and tried to work with the CCM more broadly, but really a peer, someone who worked on the CCM under last cycle or was part of your community who knew the process well. And so having a mentor that could work with you, help you understand the documents, help you navigate the politics was really one of the most vital protective things that we could offer someone to be really effective on the CCM. And so it was one of our major findings and came out strongly in the qualitative work as well. On the con side, these are something, a lot of these results, I think, echo some of previous findings from the research and work that you all have done. But on the con side, we absolutely do see that community participation did steeply decline throughout the allocation cycle. So in funding request development, we saw that about 84% of our community and non-community sample were participating in funding request development. But when you went to later things like grant making and grant oversight, we found that around only 50, sorry, that's my dog, only about 50% of the sample was participating in grant making and grant oversight. And so really big drop-offs as you move towards grant making. Here, highlighted in red, are the columns in which community were significantly less likely to be involved than non-community representatives. So in grant making and in grant oversight, we saw significant differences in the level of participation by community CCM folks versus non-community. When we unpacked this, because this was one of our goals of the survey as well, was not just to say, are you in the room or not, but really to ask, what was the level of your communication or what level of your participation? What were you asked to do? So when we unpacked this, we saw that most likely people were asked to discuss a need, a gap, a priority, or to present community evidence. But they were much less likely to be involved in things like developing a work plan, developing a budget, or reviewing a final document for submission. So some of the things we might think have a little more teeth. Here, highlighted in red, are the two things that we found significant differences statistically. So community were less likely to be asked to discuss a need or gap than non-community members, and they were significantly less likely to be asked to review a final document before submission. Unfortunately, in this slide, I had to highlight the entire thing in red. These are comparing community and non-community participation in grant oversight activities. So in terms of reviewing performance of a PR or SR, community were significantly less likely across the board to be asked to participate in oversight activities. And so this was one of the big calls of our data, was to try to find ways to support community in their oversight role, because it really came out strongly that there were gaps here. So in addition to community participation and inclusion, we also tried to measure what people's experiences were like in the room, how they felt as CCM members, and some of their experiences with the process. So we unfortunately did find that there are some high levels of discrimination and intimidation of CCM members, of community members at the CCM level. So we found that 41% of community reps said that they experienced discrimination on the CCM, and 38% of reps experienced intimidation. This was worse for key populations, and these were significantly higher numbers. We found that 50% of our key population representatives said that they experienced discrimination, and 43% said that they experienced intimidation. And I think this was a finding that we found that came out a lot in the qualitative as well, that in situations where there are hostile governments or difficult political environments, it can be very difficult to navigate those spaces as a key population member. And there has to be better support systems to support not only their perspectives, but the people themselves as they go through these processes. We did measure also what kinds of things people were doing to push back, find power, and find space in these situations. And I think this slide is a hopeful one for me. We did find that across the board, CCM members and community members are finding ways to get power. They're finding ways to get their voice heard in a variety of settings. You'll see that this slide shows what people are most likely and less likely to do, but these numbers I think are hopeful. So at its highest end, we see that around 90% of community members are saying that they have spoken up in CCM meetings, they've presented community evidence, they have disagreed with other members, they have voted against government. On the lesser side, with smaller percentages, we do see that around 30% of folks said that they had escalated a CCM issue to a multilateral, to Geneva. 25% had requested a change in a principal recipient. And about 20% had refused to sign a funding request. So these are ways that community members are pushing back. And I think there's a lot of work here to unpack where and how this is happening and how we can best support people to do these things. So those are some brief overview of the results. And we have used a lot of these results to generate some recommendations from the in conjunction with our steering committee. And I know that we want to talk about how the results fit into these recommendations. And we would love to hear also from you all about what your thoughts are about how this data set fits in with all the other research that's out there, what kind of recommendations you see coming out of these findings, and how we might be able to push some of them forward. Here are some of our recommendations for the Global Fund, which include improving transparency mechanisms that don't depend on the PR, how to get data directly to communities and empower them to use it, how to strengthen accountability funding streams for CCM functioning. A lot of our participants spoke about how they know there is money for CCMs and for community participation, but there's not transparency into how those budgets are being used and if they're actually getting to community. Trying to improve dissemination of CCM policies and guidance. We know that Global Fund does have a lot of great policies on the books, and that's so important. But the dissemination of that information and the enforcement of them is where we found that there needs to be strengthening. Also, the strengthening the escalation and whistleblowing mechanisms. We found that the majority of folks were aware that there was a way to escalate an issue to Geneva. There was a way to escalate an issue of discrimination or intimidation, but few were using it. And that was due to comfortability, fears of retaliation. And so really strengthening those mechanisms would be really important. Lastly, here are a few of our recommendations for other stakeholders and for donors that come directly from the data and ways that we think could help to empower community on and off the CCM. The first is about developing a peer-to-peer mentorship, really a formalized, scalable way to link people to mentors and fund and support that process. The second is to build a cross-country learning forum for civil society. We found clearly that when people were able to speak to each other about the kinds of techniques they were using to get power on their CCM, they felt more comfortable doing it themselves. They felt that there was safety in numbers, and they could learn from each other. So facilitating those cross-country learning platforms would be ideal. And then lastly, a fellowship program or some way to support CCM members, really take the burden off of all of the work they have to do to organize civil society, getting them a support staff in some way to help do some of that work so that it doesn't seem so daunting. And that's it from me. Thank you so much. I know we have many members of the RISE team here today, and so questions can be directed to any of us. Thank you again.
Thanks, Jennifer, and thanks for a really good presentation. I have to say that we ran a similar studies in the previous job. It was smaller, it was not as thorough, and a lot of the qualitative outcomes were quite similar. So it's really good to have something. It's really good to have something that's a bit more accurate and lets us quantify things a bit better. And hopefully we get to see over time how things move. Do we have questions from anyone for the team? Okay, so feel free to ask questions in the chat. Oh, Angela, yeah, go ahead.
Yeah, sorry, I couldn't like raise a hand in the bottom, but thanks, Jen, for the presentation. I would just like to know if you have segregation of the community members in terms of gender diversities. That would be also really interesting to know if we have some ideas of how this can be connected also to more specific kind of stigma discrimination to some key populations. Thank you.
Yes, so we do have this, and we you know, anytime we cut the data into smaller sections, we know we can maybe we see less power with making those statistical comparisons, but absolutely doing an analysis, a gender analysis, and also looking at we do have by key population in terms of MSM, sex worker, PWID, trans, and so we can take a look at experiences by key pop group as well overall with the data. So it's definitely one of the analyses that we are targeting for the next deeper dive of analysis. And so I appreciate that comment and good to see you.
Thanks a lot, Jennifer. I'll let people, there's a few questions in the chat and let's you address them there because sadly, we're about to close the call and we have a couple of things to go through. So thanks a lot, Jenny, for a really good presentation. And I know that we'll hear more about the RISE study and we're really looking forward to the full report. So before we close the call, one very quick announcement about the Summit of the Future. Sorry, it's a bit of a hodgepodge today because it's the first call of the year with a lot of things to cover. But the Summit of the Future is taking place during the United Nations General Assembly Week in September 22nd or 23rd. It's in a very long time. You might not have been paying attention, but the first draft of a pact, which is more or less the equivalent of what of a political declaration would have been for UNHLM, has just come out, and it's not talking a lot. It doesn't say much about global health, which is a bit worrying. If you don't know much about the Summit of the Future, it's around like the idea is to highlight how we can enhance cooperation across countries to face today's challenges, etc., etc. It's a fairly important process because it's fairly high level, and so you can comment on that first draft of a pact. You can make those comments online until February 12th, so that's next week. It's coming fast. There's a call organized on February 21st, not by us at all, but by people running the Summit of the Future that you can join. And I've just put all of the details in the chat, so go and have a look. So that's for your awareness. If you have any interest in global processes, you should really take a look. And with this, it is Priyanka who is going to present our annual report in 60 seconds, which I'm very impressed with.
Thank you so much, Quentin, and thank you to all the presenters who came before me. So this is our report to the membership that we do every year for the past 3 years in this format, which is engaging and is available on our website. So how do you navigate to it? You can just go to our homepage and go to the last end of the page and look for GFAN publications, or you will find it under the blog posts on our website. Also, you can find a direct link on our Twitter, Facebook, and also on our LinkedIn page. I'm just going to show you a quick preview of our fantastic report here. It gives us not only the things that we have been up to as a network, as a group of people in 2023, but also a sneak peek into what is coming next. Of course, updates on how the GFAN team has changed in the last year. And I will directly move us to a page which I find very, very interesting, which is the growth of numbers. The numbers that we have seen growing in the past year, and how our Twitter followers have grown and Facebook followers have grown, and of course, how our individual members have grown. So every year we continue to become a stronger and stronger network. And that's thanks to all the wonderful work that you people do and we do as a community together. Apart from that, in this report, you will also find some fantastic snippets that made our hearts really, really warm from the feedback that you have been giving us on our survey. The annual survey is still open, so you can still continue to warm up our hearts and still continue to give us our feedback. Again, the survey is also available on our website, but some of the initial thoughts and comments and feedback from the survey made it into this report. Apart from that, you will find a timeline of the engagements that we plan to undertake in the next year, or sorry, not the next year, in this year. And here in this timeline, you will also find under July, you'll find that we are, of course, focusing on the AIDS conference, but also, as we know, we are just 20 months ahead of the replenishment. This will also be the point where we will be launching our community NCS ask for the 8th Global Fund replenishment. So that's the plan. In case we've missed something on this, something that needs to be on our radar, please do let us know, and we'll be more than happy to populate this page as we go forward. And again, you can find this report on our website, and a direct link is also available on our social media. Thank you so much.
Amazing, Priyanka, and sorry for squeezing a 5-minute presentation into just one. So we really want to thank everyone for this first call. As we saw, we grew really quickly as a network last year, and it's been very exciting to see, more and more of you coming every 2 weeks. And we hope that our work is useful and will keep being useful for the next year. And as Priyanka reminded us, we're 20 months away from the next replenishment, which is something I really would rather not think about. Thanks, everyone. Thanks again for absolutely fantastic presenters this week. And we'll see you in 2 weeks. We'll be talking about the Stop TB board meeting, which took place this week, and a recent study that has just been published and whose name suddenly escapes me. Thank you, everyone. Have a great rest of your day, evening, night. Take care and see you in 2 weeks.
Bye.
Thank you so much. Bye, everyone.
Bye-bye.
Thank you.